So this is our center. It's interesting. This is an interesting topic. I hadn't really thought about avoiding reschedules. And I asked my surgery schedule team, we have a bunch of surgery schedulers. And ironically, at our surgery center, we reschedule over 100 cases per month. We did 2,300 joints at our surgery center last year, and we're rescheduling over 100 cases per month. So I don't know if I'm the best person to give this talk, but I will certainly give my perspective. Prior to surgery, we consider that rescheduling. So if the day before or 3 months before we have someone scheduled on a certain date and we need to tweak or change something, whether that's coming from the patient or from me as a surgeon or from someone saying they're not ready for surgery, that's considered rescheduling. And we're doing that over 100 times per month in one surgery center. So that's a big deal. Now, if it happens the day of surgery, we consider that canceled. So that to us is the worst case scenario, because that means that if we have a canceled case, we don't have enough time to put another person in that slot. So it's so important for us to do about 16 joints a day. And if we screw that up, then we've done something wrong. If we could turn up the volume here. Atul Gawande is great, but he gives a great talk here.
I think it's not just how good you are now, I think it's how good you're gonna be that really matters. I was visiting this birth center in the north of India. I was watching the birth attendants, and I realized I was witnessing in them, in extreme form, this very struggle, which is how people improve in the face of complexity, or don't.
So that was alluded to earlier by Caitlin and SCA, and we're doing much more complex things in our surgery centers these days, and certainly doing total joints in unhealthy patients is certainly a complex thing. In the hospital model has always been, we're going to do a short preoperative preparation, we'll do the surgery, and then we have this long postoperative recovery. But in our surgery centers now, we have to move that, and we have to improve how we get patients ready for surgery. And that cadence has to happen much differently now. So what used to be the case was today we schedule a surgery and then tomorrow off to sleep they go. We can go rapid fire. If we're not going to really prepare patients for surgery, it's very easy to book them for surgery and operate on them the next day. But those days are long gone, especially when we're optimizing patients to do total joint arthroplasties. Because unfortunately, optimizing patients means that takes time to do that, because I have to get a lot of things accomplished. When I schedule their surgery, I have to look at all their risk factors. I have to optimize those. I have to get any cardiac clearances or any other clearances I may need. I need to get them to the joint class that we just heard about. All that takes time, and it's different for different surgeons. So if I have surgeon A that only is booked out 2 weeks, and you compare that to surgeon B that's booked out 4 months, that means a totally different thing in terms of getting that patient ready in time. Now, you have to remember, we've heard from internists, anesthesiologists today, nurses. Remember that orthopedic surgeons have picked up, and we have chosen to use a scalpel over a stethoscope. And there's a reason why we did that. It's because we hate stethoscopes and we hate all these medical issues. But unfortunately, as joint surgeons, we have to become very good at it. And the good news is, these aren't really medically complex issues. There's only a handful of things that we have to optimize. So the complexity and what things we have to deal with for modifiable risk factors are actually pretty simple. Even us dumb orthopods and joint surgeons can figure out how to modify these risk factors to improve the patient experience. What is the biggest challenge for joint surgeons is not the medical complexity, it's the logistical complexity. And that means the following. It's not about the EKG. It means, where do I get that EKG? Who's ordering the EKG? Who's interpreting it? Who's ordering that next stress test? And that, around the country, is very complex and different. And to get the right organization to handle that logistical complexity is the key to avoiding those reschedulings. So I don't believe in luck. I believe in preparation. And Bobby Knight said it well, and I believe the same. That is very key. One of the things we have to deal with is patient anxiety. They're anxious to have a surgery. There's a lot of unknowns for our patients, and that is anything from understanding what kind of pain they're going to be in after the surgery, if they're going to be independent afterwards, if they're going to be able to drive after the surgery, right? These are all things. When do I get back to a normal life? These are all things that we have to turn from things that are unknown into known. That's dealing with that patient anxiety. And that is what we call E squared, going from unknown to known. And to do that, we have to educate and we have to engage our patients. E squared, educate and engage. That's the key to this. So what do we mean by educating? So for educating, at least for us as new, we have to turn all those unknown things that both the patient and the caregivers don't know and turn them into known things. And then we have to educate them on, if this happens to you after surgery, then what do I do about it? That for us is the real key of educating a patient before the surgery. So if something happens after surgery, if there's a dressing issue, if there's leg swelling, they need to know what to do next. They need to not be surprised by that. They need to be educated before the surgery, because if you don't tell them about these things and you don't educate them, what's going to happen to them? They're going to call, they're going to show up in an emergency room, they're going to end up in an ER somewhere as a result of you not educating them enough to expect some swelling after a total knee arthroplasty. So that's part of the education. The other thing is we really have to get our patients engaged. And this is really on the patient and on the caregiver. So it's our patient that really identifies who's going to help them after surgery. It's our patient that decides to attend the joint class. They're asking questions. They're participating with our apps that engage them. They're returning their clearances. It's so important that the patient is really engaged in the process of getting ready for that surgery. That is so critical. So you have to remember that who wants a patient home after surgery? Remember, the patient is all about not going to the hospital. They would much prefer going home, but no one else wants that patient home, right? The daughter doesn't want them home, the son-in-law, the husband. None of these people want this patient home right after surgery, because it means that they're going to have to take care of them afterwards. So for us, the joint class is not only about the family and the patient, but it's about getting that patient's family educated. And they have the same type of anxieties. There's a lot of unknowns. Am I going to have to lift mom up to the bed? What am I going to do about the toilet? All those things that I have to educate the family about is probably even more important than educating the patient. So turning all those patient unknowns and the family member unknowns is very important. So to me, what is an educated and engaged caregiver? What that means is that after the surgery, they don't have any questions. So I tell them the surgery went great, everything went great. There's no questions for me afterwards. If I have a caregiver that asks me a question about a dressing, or what to do with crutches or a walker, or what do I do with this, or what I do with that, that means my system, my process of getting them educated, engaged, failed. So my point is that when a surgeon goes to talk to a family after surgery, they need to have zero questions, because they already know what's going on. That's the most important thing, because remember, patients and family don't hear anything you're telling them after surgery. The time for engagement and education happens well before the surgery. They don't hear and they don't listen to things that happen afterwards. Because remember, when we're optimizing, we want to avoid all the readmissions, all the problems that happen. And in order to do that effectively without getting them readmitted, remember, patient preparation is the key. And this optimization can be quite complex, right? And if you don't have a logistical way to handle all this complexity, you're going to have readmissions. And that logistical nightmare can be a real problem if you don't have the organization. This concept of a perioperative surgical home, I think, hits it spot on. Each individual orthopedic practice needs to have that at their joint center. You have to optimize them. You can't rely on an internist that lives an hour and a half away for them to do that. So when we talk about simple things like identifying risk factors, recommending modifications, and reassessing that risk, that process happens. And it rehappens throughout this entire process. The problem is identifying the risk factors are simple. Great, they have diabetes. Great, their A1C is too high, or the albumin is too low. But the problem becomes, and the complexity becomes, what do I do with that information, and how long do I delay before surgery? That complexity of modifying something, reassessing how they did, and doing it over again. That's where the logistical nightmare happens. And that's where a lot of these readmissions occur. And that's what we have to fix. And the question is, where along this path do I actually schedule the surgery? Do I schedule the surgery at the very beginning? Do I schedule it after they've lost the weight? So take, for example, obesity. Do you schedule your patients as soon as you see them for the first time and tell them then to lose 20 pounds to get a BMI of 40? Or do you wait for them to lose those 20 pounds and then they come back to your office and then you reschedule the surgery, right? So the same thing applies for all these modifiable risk factors. We heard an example earlier today about EKGs, right? The complexity of EKGs. Something as simple as getting an EKG, if it is sent over to me the day before and I have to read it, that would be a joke. I need a cardiologist or someone else that really knows how to read an EKG to look at it and decide if we need to do a stress test. And that cannot happen the day before or the day of surgery. If that happens, then you get canceled surgeries, and that is the real problem here. And the same thing goes with diabetes. You get the idea. All these modifiable risk factors have some issues. The key to all this is checklists. And obviously, pilots know this very well. Atul Gawande does a great checklist manifesto. You need that type of checklist in your preoperative clinics to get your total joint arthroplasty patients ready, or else you'll have readmissions. This is just Dr. Mehta and his plane as we look through it. So if you get an example like Surgeon A, if Surgeon A has a long wait time and they see that person and schedule them the day they see them for the first time, they have all kinds of times to get that patient ready. So I may have 3 months or 4 months to get a patient ready after I book them for the surgery. And there's a good chance in 3 months' time, I can get them ready for that surgery. But if we do the same thing again, if we have Surgeon B that has a very short wait time and I try and get everything done, i.e., I optimize the risks, I send them to the joint class. If I try and do all those things in a short period of time, let's say 2 weeks, then there's a good chance that I'm going to have to reschedule because they're not quite ready, or we didn't get that EKG, or I'm going to have to, worst case scenario, cancel them the day of surgery, right? And then the final option is what I would consider a conservative surgeon. And that surgeon is one that is hesitant to ever put them on the surgery schedule, meaning they do everything they can to get that patient ready. And once BMI is met, all those criteria are met, then they're going to put them on their surgery schedule. The problem with that is a lot of times patients end up going somewhere else, or they go get a second opinion because they don't want to wait all this time. They don't want to do all these extra things. But I would consider that a conservative type surgeon that waits to put them on the surgery schedule to the very end. You know, there's always going to be unavoidable reschedulings and unavoidable cancellations. 3 or 4 times a year at our surgery center, we've done all the risk factors. We've had them sent for stress tests. And lo and behold, you put them on the cardiac monitor right before surgery, and they're an AFib with RVR. Those are some things that you unfortunately just can't avoid, no matter how good your patient preparation is, or the day before surgery, they end up getting COVID, right? There's some things that we're just not going to be able to avoid. But in general, if you're very diligent and have a checklist, you're going to avoid these reschedules and these cancellations. And I think with that, I'll turn the time back over to Dr. Kagi.